the QI planning and action planning. So that's important. But in terms of wider information, sorry, just something has popped up on my screen about the clinical audit cycle. Obviously, we have a number of other training programs. We have our fundamentals in clinical audit, which is available in HSE land and in the virtual classroom, and we have advanced training in clinical audit. So all of the steps in the clinical audit cycle are explained in much greater detail in those, as well as within our practical guide. But I just wanted you to remember the governance piece is critical to setting off on your clinical audit journey. I suppose, secondly, what I'd like to say about quality improvement is that, you know, any improvement you make out of a clinical audit is good. I suppose often people are maybe not very happy if their clinical audit only leads to an improvement maybe of 5 or 10% when you come to undertake your re-audit. But it's important to note that any small win is a win, and any small improvement is an improvement, and that will benefit the patient and ultimately may well benefit you as staff members as well. So not to feel disappointed, I suppose, if you're not achieving the standards that you think you should be achieving in your re-audit. Any small improvement is a win, and you can consolidate and build on that. And importantly, you're bringing staff with you every time you do achieve that small win or improvement. And I know Dervla will talk a lot more about that in her session just after myself. So next slide there, Celine, please. Okay, so look, you know what the aim of the webinar is. It's going to give you some practical guidance on how to effectively plan and implement quality improvement based on the findings of your clinical audit. But while we're here today to talk about QI in the context of the clinical audit cycle, you can use these methodologies and the training that you pick up here today, the learning that you pick up here today in any quality improvement. So perhaps, you know, you've gotten feedback from a service user survey or a staff survey, or perhaps you've had an incident that you've reviewed within your service area, or perhaps there's, you know, some regulatory feedback that you've gotten in relation to standards from HICWA, etc. So what you learn here today can help you implement a quality improvement plan as a result of any of those things. But we're here today to talk about it in the context of clinical audit, but it may well be of benefit to you in other scenarios as well. Next slide there, Celine, please. So the key points to note in relation to this stage of the clinical audit cycle are very well documented and outlined in our practical guide. But as I was saying earlier, the first thing to consider in your clinical audit is your identification of your clinical audit stakeholders. So if you've done that at the commencement of your clinical audit cycle, they should still be there and available to you and on board when you're coming to agreeing your quality improvement plan. Your quality improvement plan will include ownership of the actions and the agreed timeline. So, you know, you as the lead, if you are the lead for the clinical audit or the person who's undertaking the clinical audit, you may not be taking the ownership for the actions. So again, looking across your multidisciplinary team, who the owners of those actions will be and agreeing timelines for the actions with those staff. And, you know, bearing in mind the busy environment that everybody is working in, you know, people may need to take periods of leave, etc. So, you know, giving yourself reasonable timelines. And again, I know Dervla will talk about this and Ronan will as well in his summary towards the end. Where possible, then you should be using your QI plan, should use agreed templates for that. Again, I'll share one with you in a couple of moments, but there is a useful list of documents called the Clinical Audit Toolkit available to you now on the HSE website. And this has a number of templates, for example, for your clinical audit proposal form, your clinical audit report template, and also a template for QI. So just to know, again, those are available to you and to utilize those. What we're trying to do is, I suppose, simplify and make life easier for you in terms of utilization of some of these and to keep your projects on track. The QI plan should be disseminated and communicated to all relevant stakeholders and within your governance reporting line. So again, going back to the start of the audit cycle, you should have identified who your relevant stakeholders are, who your governance reporting lines are. You might have a specialty governance team. You could have a quality and patient safety committee within your hospital. Depending on your audit topic, it might be a drugs and therapeutics committee, whomever. And if you're not sure, discuss that with your line manager, or you may have access to a quality and patient safety advisor or a clinical audit facilitator within your service, hospital or community setting. So, you know, discuss it with them if you're not clear on who those relevant stakeholders might be. This is what's really important, that the actions then are closely monitored for implementation. And I suppose the reason we are holding this as our second in a series of webinars this year is that the feedback we've been getting from some staff is that, you know, they've identified quality improvements that need to be made, but this is the part that's challenging. It's not actually happening. Perhaps they don't have the buy-in from staff, or there isn't an accountability structure there, or a governance structure that's monitoring it. So it is really important that, you know, at least on a quarterly basis, that you're going back, you're checking with the stakeholders that the quality improvement plan has been implemented, and that you're communicating that information then within your governance structures, whatever that might be. Because if it's being monitored, you know, it's more likely to you know, people will be asking questions, has this been implemented? And then you should undertake your re-audit. And I suppose then, you know, your actions have been implemented. You want to see the impact of those actions, and has it led to an improvement in your standards? So, you know, if your trend is upwards, it doesn't matter how small that trend upwards is, that's an improvement. And as I said, that's to be celebrated. And then final slide, I'm just going to share the template that's available in the toolkit for quality improvement action planning. So, you know, again, you've probably seen these before with other plans that you've made. It's fairly straightforward. You've got your recommendation that's based on the findings from your clinical audit report. Together then with your team, you're identifying the actions to address that recommendation. And that's where Derval is going to come in and give you some information, skills and tools around how to identify what actions need to be made to meet the recommendation. You're identifying then who's responsible. So while there may be a team helping you to implement the recommendations, there should always be one named person then that can be the person that's followed up with then for the action planning and the monitoring of it. You do need to set target dates. Again, that does move people along and push the agenda if there's a target date that people are monitoring against. You can record the status then of the recommendation, where it's at, you know, is it overdue, has it started, not commenced, etc. And then you may like to make comments. And within the comments, you know, you may outline why recommendations aren't moving on. Perhaps it's due to resource implications, maybe a staff member, you know, that post's become vacant or whatever, somebody that had a critical role within the action plan implementation plan. So, you know, documenting the reasons why things aren't progressing, or if they have progressing, documenting that as well. So I'm going to hand over now to Derval Hogan, Programme Manager in QPS Improvement, and she'll take you through some of the tools and techniques around QI. So thanks very much, Derval.
Thanks, Majella. 2 seconds there, and I'm just going to share this as a slideshow. Yeah. So hello, everybody. It's my absolute pleasure to be here today along with my NCCA colleagues to discuss quality improvement with yourselves to support the completion of the completion of the actions out of your recommendations. And I suppose, like Majella said, just to give some very fast, I suppose, very quick journey through some tips and tricks around how to utilize quality improvement methodology to support yourselves within closing out that clinical audit cycle. So today I'm going to, within about the next 25 minutes, I'm going to take you through this journey that I have on the screen here. It's the 7 steps around implementing a quality improvement project. And I'm really going to take you through the tools and resources we have that you can utilize on each step along the way. So we always look at the getting started point, which is very much where you have your QIP, you know, you have your recommendations, you know what you need to do. Then you'll be bringing people together. You have to bring the right people together into the room to help support that understanding of the problem. So as Majella said there, you have your recommendations. So you have an idea about where the issue is. So you have that piece around what the problem is. And now you need to work on developing an aim around what do you want to achieve within this QI initiative to address that the actions that are coming out of that recommendation. And then there's ways of identifying your measures, then moving on to the actual testing of ideas for change. And I suppose most importantly, and whilst it's at the end of step 7, it's probably a step that you should be thinking about since the getting started step. It's about how is this going to keep going once the project, in inverted commas, ends? How do you make this that is sustainable within the area that's happening in, and that if it is an idea, if it's a test for change that has worked well and should be spread elsewhere, how is that going to happen? So that's something you have to be thinking about throughout the journey. So I suppose we often ask, what is quality improvement? And I suppose there's many definitions. And within the HSE, we use the definition that's up on the screen there around combined and unceasing efforts. Sorry, not sure why that's happening. Around combined and unceasing efforts of everybody, including healthcare professionals, patients, and families, to make changes that will lead to better patient outcomes, continued experiences of care, and continued development and supported staff. There's many other definitions out there as well, like the Health Foundation defines it as a systemic and coordinated approach to solving a problem using specific methods and tools with the aim of bringing about a measurable improvement. I very much like the first one. I like the focus on patient outcomes, really the focus on patients and staff and improving within that space. I like that. But there are many different examples. And there's a quote there that says, all improvement is change, but not all change is improvement. And that can be attributed to Dr. Don Berwick, the co-founder of the Institute of Healthcare Improvement, which we'll talk about in a minute. And that really emphasized the need that we just have to have very clear data-driven approach to change. As not all changes actually lead to better outcomes, and we need to be able to measure that and determine that. So we really have to focus on an evidence-based change and having a positive impact on patient care and outcomes rather than a change just for the sake of change. So what we come to next is the model for improvement. And I would imagine that a lot of people on the call have most likely heard about this. It is one of the most popular QI models in use in healthcare settings. And it was adopted by the Institute of Healthcare Improvement. So you might also have heard of the IHI model. You might also have heard of the Plan, Do, Study, Act method. These are all the same piece. They're all descriptions of this. And as you will see, the model has two parts. So there's what we call the thinking part and then the doing part. So in that thinking phase, you have three questions that you can see there on the screen. So you will first evaluate your problem looking at them three questions. You will look at what do you want to achieve? How do we know if the change is an improvement? And what changes can we make that will result in an improvement? So the key is, again, as I said earlier, not just changing for change's sake. It's really that improvement piece is key. And then the second part of the model, that is the doing part. And this is where you're testing, implementing, and spreading your change, utilizing the Plan, Do, Study, Act cycle. So this is a four-step model for improvement, and it's used to test if the change is an improvement. So it's really very much focuses on small tests of change and allowing you to work through the Plan, Do, Study, Act cycle quite quickly and iteratively. So you can determine if a change has worked or not as you go through it. So while it supports both very simple and complex improvement, the model is very easy to use and to implement. And then the use of the PDSA also means changes can be both easily implemented while allowing for the improvements that are achieved to be sustained as well. So I suppose there are a range of benefits to utilizing this model. It's proven to be highly effective specifically in healthcare settings, and it has applications for many types of projects and at any scale, large, small, in between. And it reduces the risk because you're starting small and systematically testing change before implementing change on a wider scale. And I think one of the key things to say about the Plan, Do, Study, Act is to not forget the Study Act part. Don't get caught in finishing doing a PD. You have to do the full cycle because that is where you will really see within the study section is where you'll really see did this actually result in an improvement, or did this just partially result in improvement? Do I need to refine, or did this just not work at all, and do I need to scrap it and move to the next? So it gives you that opportunity to do what we call the 3 A's. So you get to adopt it if it's worked well, you get to adapt it if it's just needs little tweaking, or you get to abandon it if it hasn't worked. So it really allows for that. And I think it ties into what Majella said there, where, it doesn't have to be, everything doesn't have to have been achieved. You're achieving the pieces of change, you're achieving it by doing the cycle, and you're seeing it. There's no failure here. It's all about looking at whether you'll adopt, adapt, or abandon. So why would we utilize QI, and why would it be of any support to what we're trying to do? And I suppose it's because we've seen what QI is. It's a systematic approach that seeks to enhance our operations by examining how we do things the way we do and discovering more efficient methods. We can really ensure that we're streamlining processes and reducing costs by completing the same workflow in less time and with fewer resources. We can produce improved documentation due to simpler processes, better training with an increased understanding of what is involved, and improved quality as a result of all of the above. So that's where we go back to the better patient outcomes, better experience of care, and the improved piece for the staff as well. So I'm going to just take a few minutes just to talk about engagement for improvement and the actual real importance of that within any quality improvement initiative you're trying to drive out. So the research very much shows us that a certain number of people are very influenced by their mind over their heart, I suppose, in relation to supporting an improvement. Interestingly, it might not be the way you think it is, because that is really where we're at. That 5% of people are really influenced by their mind to support an improvement, whereas the research shows that 95% of people are influenced by their heart. So what does that mean? So I'm just going to tell you a very brief story to just help explain what that actually means. So a number of years ago, as part of a hospital group reconfiguration, staff were asked to relocate from a small hospital to a larger hospital. So this was located in an adjacent town, only about 15 minutes away. Now, this was going to be a great opportunity. It was put forward as a great opportunity for staff. They were moving to a larger hospital, had state-of-the-art technology. It was a full a broad specialty load compared to the smaller hospital. It was really seen as quite a positive opportunity for the staff, but there were very few volunteers. Despite the fact that they knew their smaller hospital was being downgraded, so people still wanted to stay where they were. And why was this? And really, they wanted to know, why are people not moving? Like it just seems like the obvious option would be to move. But when investigated, they realized that the resistance to the move was nothing to do with promotions or experience opportunities that they had been selling. It really came down to a number of things that are far more on the heart side of things. It came down to a fear of the unknown. It came down to the fact that, my childcare for my kids is 5 minutes from the hospital I'm in now. Whereas if I want to get to drop them off and get into work on time, I actually now have to do a 30-minute loop, whereas before I only had to do a 5-minute loop. So it's that piece. And also it was that feeling of a family in the smaller hospital, and that connection and that fear of just becoming a number in the larger hospital. So it's very much about, sometimes when we're trying to influence people into our change, we can assume that we know what will influence them, but we have to take a step back and determine what will actually influence people to come along with me here. And you do have to look at that heart piece. So your engagement with colleagues will be really key when you're trying to drive forward quality improvement. We all know in relation to any level of change management, not everyone will be open to change and innovation. As much as you might think now that your plan is absolutely the best plan ever and is going to make all these improvements, there will be people who will not be on board for various reasons. So what we're looking at here now is the distribution of innovation. So it's also known as the diffusion of innovation theory. It was developed by E.M. Rogers in 1962. It's one of the oldest social science theories. It originated, I suppose, to explain how over time an idea gains momentum and distributes or spreads through a specific population or social system. And it's really, really relevant for implementing improvement or trying to do change. So we can see that if we look at the left-hand side with our innovators and our early adapters, they're always going to be really excited about something new, but they can be in your minority. But then on the other side, over on the right side, you can also have the laggards, and they may appear resistant to change, but they can also be in a minority. So you can very much then have these people in the middle, which is really going to be where the majority of your people sit. So I suppose you have to think about who are you going to focus on and where are you going to put your time and energy. You could really put a lot of time and energy into the laggards and really try and convince them of the importance of this change and what's happening here, but you might never actually convince them, and you might have wasted valuable time from having been able to influence the others in the middle. Now, you might also remember that you will most likely need to manage your innovators and early adopters. They might get very excited. They might get very carried away. They'll be trying to run on. But at the same time, they might get distracted by something new again. So you need to try and keep them with you and bring them along. So the group you really want to be looking at is your early majority group. They are a group that if you can get to them, if you can move across that chasm and get to them, they will influence your late majority and they will follow the early majority. And then even your laggards might eventually, as they won't want to be left behind. But you really have to be quite clear on who, that piece of a stakeholder piece, which we'll talk about in a few minutes. But you have to also be clear on where are people maybe sitting along this curve and who do you need to work on to bring the most people with you. So Majella discussed in her presentation there briefly, all the areas where improvement ideas can come from. So, today's focus is around clinical audit and the recommendations you have from there and the development of your QIP and quality improvement ideas and etc. coming out of that. However, there are a range of areas. So, it can be from feedback, could be experience surveys, it can be different pieces like that. You can also have your data, which is where your audits sit. You can have standards. And then you could have, your research data as well, published studies, conference proceedings, etc. So you really need to be sure that you're looking at ideas from all perspectives. Because you want to be sure that you're looking at it from the perspective of somebody who's affected in maybe a different way than you will be from the change you're doing. So by using that different lens to look at your idea, you will be able to come up with a novel approach. So sometimes, as Majella said there, you will have your recommendation and you're going to be trying to decide what actions, what do I need to do here? And one of the ways, there's a range of ways to do that, but you can utilize a number of tools that can be found in our quality improvement toolkit, which I'll talk a little bit more about at the end. So I'm just going to very quickly take you through a few of these tools, some of which I'm sure you've probably used already anyway, because oftentimes people have done this type of work in some format without having a name on it. So the first one is your cause and effect diagram. And the more commonly used name is the fishbone diagram. So as you can see there, this really gives you a pictorial display of possible causes of problems or factors needed to ensure success of some effort. So you're looking at what are the causes of problems and what do you need to do to have success in relation to your quality improvement approach. It really aims that you're going to show all the causes leading to your main event, which is at the top of your fishbone there. And each major branch of the diagram corresponds to a major cause or class of causes that directly relate to the effect. And then the minor branches are showing a more detailed causal factors to that major cause. So, I won't go into this in too much detail since this is just a lunchtime webinar, but I will talk about our toolkit near the end, and I'll be able to give you a bit more guidance on where to go to find out more on each of these. So the other piece that you could utilize is process mapping and utilizing swim lanes within process mapping. So this really allows you to walk the process from end to end, and it maps out each stage of the process by placing the events into lanes, but these lanes are aligned to people involved in the process. So the one you're looking at here, this demonstrates patients and staff roles in admitting a surgical patient to the ward. So it just really allows you to see where the duplication is occurring for both the receptionists and the nurse. And is that clinically required duplication, or is that duplication that you can review and lean down the process? So that's part of what the process mapping allows you to do. There is another methodology, which is the 5 whys. So that really allows you to distinguish the symptom from the cause. So it allows you to ask a number of questions. Now, the number 5 is there because it is felt that you have to get a certain point along the way before you're going to get to that root cause. However, it could be more, it could be less until you get to the root cause, but you just have to keep asking the question why until you get to the root cause, because generally that first why and the answer to that first why is only a symptom, and you have to work through the excuse and blame cause down along until you get to the actual root cause of what was actually wrong, because your symptoms are very superficial, whereas the root causes are the real issues. You're also going to want to ensure that you have an aim. All quality improvement projects will have an aim. This is based on the model for improvement. That aim really seeks to answer the question. It looks at what are we trying to accomplish, that very first question in the model of improvement. And it reflects the desired outcome of your improvement project. So you really want your aim to be specific, measurable, actionable, relevant, and have a time frame. So you need to be asking yourself a number of questions around, is the aim too large? You need to know who is impacted. Can the aim be achieved in the time allowed? Is it supported by evidence of experience? Where will the change occur? And does the aim have meaning for staff and patients? And there is a wonderful structure to really allow you to build a smart aim very easily, because it focuses on the population impacted, the outcome, the baseline data you have, the future state you want to have, and the time frame you want to have it within. So it's a foolproof way to ensuring your aim is smart. And then I know some of you may have heard about driver diagrams. So just very briefly, it's a visual tool for identifying change ideas and creating a testable hypothesis. So it really allows you to get down into what your change ideas are. And it allows you to represent the shared theory of change. So it looks at how things might be better, building upon knowledge gathering from research, observation, and experience. That's what it allows you to do. And it illustrates what structures, processes, and norms the team believes require change, as well as how these might be changed by applying specific ideas. So it allows you to have a range of change ideas, some of which you may not be able to complete due to where your power or influence is, but there is a number of ideas that allow you to build up and to make incremental changes. So that's just an example of a driver diagram. So over here, over on this side, you have the change ideas. So these a number of change ideas can come out of your secondary drivers, which emanate from your primary drivers, which are based on your aim. So really the primary drivers are what needs to be happening to achieve this aim. And the secondary drivers are linked to them primary drivers, more about how are we going to do this, and then the change ideas come from that. So really well-written secondary drivers will really help you identify your relevant change ideas and to go from there. So very briefly, I'm just going to touch on measurement. Like a measurement workshop could be a whole afternoon or morning in and of itself, but it's just to give you a quick overview of the language we use in quality improvement when we refer to measures. So we're looking at outcome, process, and balancing measures. So outcome measures look at your overall result. They articulate the picture of success. So you want to look at, are we making things better? Are we on track to achieve our aim? Process measures look at the different components of the system that affect the outcome. So is the process improving? Is the process reliable? And your balancing measures cross-check the consequences of change in the system for both a positive and a negative. Sometimes people feel they've heard about balancing measures maybe only in the negative, but you can have a positive balancing measure as well. So your process measures are usually leading, while outcome measures are usually lagging. Really, one of the things I'd say to you when you're trying to get your measures in place and your data in place is have a measurement plan. I can't overemphasize the importance of a measurement plan and having operational definitions for your measures, because, for example, I could interpret the availability of the bed for the patient to come into in a very different way to somebody else. So you have to be very clear about what does that mean. So you need to really make sure of that. The one thing I'd say as well is you're going to have baseline data, then you're going to be putting in your change and testing that and looking at, does that make changes to your data? Your baseline data is important, but really don't put off improving just to hone your baseline data. Have it to a point and then get in there, making the change, quick iterative tests of change, utilizing the PDSA cycle that we've talked about already. So we've talked about the plan, do, study, act. I mentioned the 3 A's already. One of the things I'd like to go through with you is just some of the common challenges with PDSAs. So one of the main ones is trying to do a lot of PDSAs at once. So trying to test a number of changes at once. This means that you're not going to be able to actually determine from your data which change, which intervention meant the change, because you're going to be testing too much at one time. Not documenting it as you work through the cycle. You have to document it. You're not going to remember. So you have to have it recorded because that helps you in progressing to the next stage. Also, doing a PDSA cycle when it isn't needed. If you know about what you're working with is something that is what you're planning to do is something that has worked already within your area, well, don't go doing another PDSA if it isn't needed. Also getting stuck in the plan phase, call it planning paralysis. Just getting stuck in there, like I said, trying to make sure your baseline data is right, like having your plans all in place. Brilliant to have, but just keep moving through the cycle. Keep going through the PDSA cycle. Don't get stuck on one part of it. And I know Majella referenced it as well, but one of these pieces is the fear of failure. People are very nervous sometimes about the aim they put forward for their project. Will I be able to achieve it? This is the whole concept of quality improvement. There is no failure here. There is only learning. And if something doesn't work, you're only going to utilize the abandon option and you're going to move on to the next. Skipping your planning phase? No. Don't skip any of the phases. You have to work through them in that way to get the most out of your PDSA cycle. And make sure that what you're testing is sustainable, that it can last, because that's another challenge sometimes, trying to test things that won't last. And then sometimes your changes not actually being aligned to your problem. can be another issue. So you have to make sure that the changes you're proposing are actually aligned to your problem, that you're not just trying to fit in a change that you might like to do into this problem. It has to be aligned to it. So if you're trying to show your data, one of the ways to do that is to utilize a run chart. It's a graphical display of data plotted in order over time. So its purpose is really to help answer the question, has a change resulted in improvement? So you'll be able to see there, you have your median line, you have your goal line. So you'll be able to see if you are reaching that goal and what is happening. So overall, run charts, again, are another piece that you could spend a lot of time going through. So this is really just to flag them to you rather than to go into them in too much detail. But overall, they are quite easy to construct. You can have both your baseline and your after intervention data in on the same graph, so you can really see that change over time. And really, to utilize them, you don't need to have any detailed knowledge of statistics. We have an Excel template that once you have the data, it will run the run chart for you. So just finally, in relation to measurement, again, as we said, measurement should be linked to your aim. It should guide improvement and testing of change, and measurement should be integrated into the team's routine, and data should be plotted over time on your graphs. So just to close out, I'm just going to very briefly flag our quality improvement toolkit. So we have the toolkit right now is aligned to what was the 4 phases of the quality improvement project. We're updating it to align to the 7 stages. But just to even give you a further update about the toolkit, at the moment, our toolkit contains 17 tools to support QI projects and initiatives in any setting. And I've listed them here on this slide. However, we're currently in the process of updating the toolkit. So we're going to have a new quality QI guide and toolkit. It will be available hopefully within the next month. And that will really guide you from your initial light bulb moment through to the QI project design, implementation, evaluation, sustainability, and spread. So it's going to be slightly differently laid out. It's going to include examples of completed tools, so you can really see how you would actually use them in the real in a real quality improvement project. So we're looking forward to releasing that for you as well. And I have already discussed the toolkit, but we also, within the directorate and within QPS Improvement, we have recently developed the Improvement Collaborative Handbook that will support staff and teams by providing background information and a step-by-step approach to organising and leading short-term improvement collaboratives. So it's really been developed based on the team's experience over 10 years of delivering collaboratives. So it's quite a good document if you're looking at a collaborative piece. We also have the Quick Patient Safety mobile app. So it's an accessible, engaging, and easily navigatable mobile app to support healthcare professionals who wish to reduce patient harm using improvement approaches. So the first 2 subject areas covered by the app are falls and pressure ulcers. So the falls one has been piloted and is available. The pressure ulcer one is in development and will be piloted between March and April of this year. And finally, I know some people on the call may already be Q community members, but if you're not, we partner with the Health Foundation to provide Q community membership in Ireland. So it's, I suppose, what is Q? I suppose its mission is to foster continuous and sustainable improvement in health and care. So we have over 5,000 members across the UK and Ireland. So it's really about helping, I suppose, everyone is there linked in to use and develop the wealth of ideas and expertise that currently exist across all people working within quality improvement. So if you are interested in it, you can contact ourselves on qps.improvement@hse.ie. It'll be up on the last slide, and I know we'll be sharing the slides after. So please don't hesitate to contact us. Finally, these are just some more resources online that you can find to just help you develop stakeholder mapping or a run chart or process mapping, etc. So Thank you very much. As I said, that's our email there, qps.improvement@hse.ie. So I'm just going to hand over to, I'm going to stop sharing my screen and I'm going to hand over to Ronan.
Thank you very much, Dervla. So for those of you that don't know me, my name is Ronan Buckley. I'm a clinical audit facilitator with the HSE NCCA team. And I suppose we've heard there this morning from Majella about the importance of having QI in your clinical audit cycle. And then Dervla has shared some kind of tools and theories of QI. And it falls to me then to try and consolidate all of that and to discuss how we might apply all of it into practice. And I'm going to do that by presenting a case study. So it is important to note just from the outset that this case study is a fictional case study. And we've chosen a fictional one because we want to kind of mash all our experiences of quality improvement projects into one and try and present it in a topic that would be applicable across all clinical settings across the country. So we've chosen a topic of transitions of care, a hot topic, and I'm going to share my screen now so that we can just discuss that case study. So hopefully that is coming through to everybody. So this clinical audit case study, so we'll start, as Majella said, at stage 1 of our clinical audit cycle. So Hospital X has received multiple complaints from GP services, public health nurses and patients regarding the lack of written information following discharge. The hospital is also aware that increasing safety during transitions of care features in the HSE's patient safety strategy. And it's also an area that's often covered by HIQA when they inspect the hospital. So therefore, a clinical audit of the provision and quality of discharge summaries has been commissioned by the hospital's Quality and Patient Safety Committee. So when we move on then to stage 2 of selecting the standards and criteria, the clinical audit team have chosen the HIQA's document on national standard for a clinical audit summary or patient discharge. And they're also going to lift some elements from their local policy. Stage 3 then for the clinical audit tool design, they've designed it. They have a multidisciplinary clinical audit team. And that team has designed the clinical audit tool and they collected their data over a 1-week period. They took 15 patients being discharged from each of the hospital's 9 wards and the emergency department. And then stage 4, they just did very simple statistics on the data that they have collected to figure out what was the % compliance with the standards that they had selected. So now we're after zooming through all that and we're on stage 5, the clinical audit report. So the team are sitting down now to write their clinical audit report to include the recommendations, and they're going to try and formulate a quality improvement plan. So what did they find during their study? Well, in general, the content of the discharge summaries were in line with the local and HIQA standards. However, the clinical audit, as often does, the results identified some opportunities for improvement. So 67% of the patients had a discharge summary sent to them within 1 week, and that was below the standard set, that was 80%. The future management section of the discharge summary was only adequately completed 54% of the time, and that was below the standard of 100%. And only 43% of the rotating NCHDs had completed the available training that was detailed in the local policy in how to complete electronic discharge summaries within Hospital X. And there was a standard of 95%. So clearly some opportunities for improvement. So the clinical audit team are struggling to identify the next steps to improve the situation. So they contact the local clinical audit coordinator, and they've suggested some QI methodologies to assist in identifying the next steps. So they decided that a fishbone diagram, as Dervla discussed earlier, would be their initial jumping off point. So we know that the problem was that only 33% of discharge, or 33% of discharge summaries were not completed on time. So as the multidisciplinary team are sitting down to consider this, they're going to look at it through a couple of lenses. They're going to look at it through the equipment lens, methodologies, materials, people, and environment. So when they're sitting down as a team and they have their NCHD representative on the clinical audit team, the NCHD rep lists PC availability as a problem. So it's a busy ward, the nurses are using the PCs, the other doctors, other clinical teams using PCs. And actually getting a free PC to sit down and do an electronic discharge summary is an issue. And then even when they do sit down, they have to access multiple systems. Looking at methods, the software that they're using is slow and they need multiple passwords, enter your password multiple times. to be able to use it. And there's no clear process in place for weekend discharges. So is it the responsibility of the intern on call, or is it the responsibility of the primary team when they come back in on Monday to complete that discharge summary? In terms of materials, a lot of the time the NCHD is sitting down to do the discharge summary maybe 5 or 6 days after the discharge, which is within the standard, but they note that the notes are efficiently, moved off the ward and back down to medical records. In terms of the environment, there's limited storage. It's a real high flow area of patients coming and going, and there's limited quiet workspace for the NCHDs to work. In terms of people, then we've noted that there's a low level of training attendance. Everybody knows how busy NCHDs are, and some work has to be prioritized. And then nobody is really keeping anybody, holding anybody accountable for having this piece of work done. And so it generally goes undone. So the clinical audit team sit down then to look at this. And the first thing worth noting is that there's definitely some pieces on this fishbone diagram that are out with the scope of this local clinical audit team. I don't think any local clinical audit team could be held responsible for altering the workload of NCHDs. That's going to be a complex issue that requires a national strategy, probably lots of recruitment and lots of redesign. So there's no way they're going to be able to address that. And also they know that they're under contract with the software company that they're doing the discharges on for another 2 to 3 years. So there's no scope to change that. So while there are factors influencing this problem, they have to decide what's within their scope, what can they change that will improve the issue, as Dervla said at the start. So there are a few low-hanging fruit, if you like, that they can change. So PC availability, straightforward, the notes being moved off the ward, and the accountability piece. So they're the bits that they're going to tackle first, and we'll talk about training attendance again in a second. So those 3 pieces that they're going to, they've decided they're going to tackle, they've entered those on their quality improvement plan. So the recommendation is that new PCs be supplied to each ward. The action to address that recommendation is that 10 workstations on wheels are to be procured. That's going to be done by the head of IT. It's going to take roughly 6 months. It's in progress, but funding has been approved. For the second one, notes of discharged patients must be available on the ward for 1 week is the recommendation. So communication to ward clerks not to file charts for 1 week is going to be sent out by the head of medical records. That was to be done as soon as possible, and we have monitored that, and we know that it's now complete. And there's going to be a check on records coming back into the medical records department to make sure that the patients have not been discharged within that week. And then because the discharge summaries are electronic, a KPI of discharge summaries completed can be pulled off pretty easily. So that's been introduced for each directorate. The report will be pulled off on a monthly basis on % of summaries completed within the 1 week by the business manager, and that has started already. And any scores of below 75% is discussed at the directorate leads meeting, and comment is required as to why the score is still below 75%. But that still hasn't addressed this problem, which is that the future management section, so one of the sections on the discharge summary, was only filled in roughly about half of the time. And the team really couldn't understand that. So they've decided to use their 5 whys model that Dervla mentioned earlier. So the future management section was only adequately completed 54% of the time. So why was that? Well, the NCHDs were unsure of where to find exact detail of the next appointment on the computer systems. And why were they unsure where to find it on the computer systems? Well, only 43% of the rotating NCHDs had completed the available training in how to complete discharge summaries. But again, we know that's a fact, but why was that? Because in their busy environment, other training had been prioritized. Very understandable, but why were they attending other training and not attending the discharge summary one? Because other training was more valued by NCHDs. And why was that? Because it had CPD points attached to it, or they were held accountable for having it done. And discharge summary training was not incentivized. So the clinical audit team considered it, and that's where they came up with this idea of incentivizing parking permits. So this is the completion of the quality improvement plan, in that NCHDs were to be incentivized to attend training. So assertive training was required to get your car parking permit. The head of medical HR was going to stand over this, and they said that they wouldn't do it for the current NCHDs, but on rotation, it would be introduced. So it's in progress, and that's to be coordinated with the next rotation. And that's the QIP kind of in its full detail. what was learned from it? Well, all actions on the QIP were clearly tied to a finding within the clinical audit report. So completing each of those actions is going to contribute to addressing the opportunities for improvement. The audit was commissioned by the QPS committee, so results and the quality improvement plan were shared with the committee, and that results in wider support for change, and the action owners are now held accountable through that committee. So it's not just on the clinical audit team to make sure that these actions are done. That's handed to the committee. Writing of the quality improvement plan was made much easier by the fact that all action owners, or reps for all action owners, were on the clinical audit team from the start. Magella noted that about having your stakeholders involved from the very start. So everybody who's assigned an action was on the team. So that's the importance of early stakeholder identification and management. The action plan is going to be monitored through the QPS committee before a re-audit is commissioned. And again, as Dervla said, better is going to be defined as success. So if you've got 54% of the future management section being filled in at the minute, if on the re-audit that's gone up to 60, 65 or 70%, we're going to be happy with that, and we know that we're traveling in the right direction. So I know we're standing between everybody and your lunch. So with that, I think I'll hand back to Celine, and there might be a little bit of time for questions, Celine.
That's fantastic, Ronan. Thank you so much. That was just wonderful. So we'll have, I think, time to squeeze in one question. I know Eric is on the call and submitted a great question. And it was a detailed question about a specific quality improvement. And the question related to the introduction of new paperwork and an ongoing measurement of its success. And Eric asked, is there any advice you can offer to assist with this project? So Dervla, I might hand it over to you if that's okay to answer that question.
Absolutely. Thanks, Celine. And Eric, thanks for your question, which I've read in full detail. So I suppose when I looked at it, what I was thinking was, I'm assuming there's a very clear reason for introducing these forms. So I suppose my thoughts would be, say, for example, if the reason behind the introduction of this form was that it was thought that this patient assessment form will speed up patient referral to the next stage of the process or to the next specialty that the patient needs to get to. I think that's a very nice measurement that you could use there to see. You could do a very quick test of change on that. You know, you can introduce the form and you can see how has that sped up the referral pathway for patients compared to where it was before. So you may need to collect your baseline data, looking at what the time to next stage was with referrals before you introduced it, then introduce it, and then you can look at the data after that. And I think, as I said earlier, my advice would be one intervention at a time. So one test of change at a time. Really keep it to small tests of change. So you could do this over, you know, your baseline could be a 1 to 2 weeks. You could do your tests over at the 3rd week. So it could be in days, or you could do it over 2 weeks. So in weeks, but really no more than that. Within quality improvement, we don't want to test at one point and then wait a number of months to do another test. That's more of a before and after piece with interventions. But this is really trying to iteratively test quickly to see what is happening. So I would really say to reflect on the reason for the introduction of the form, especially from a patient care perspective, because I know that that's what you were interested in. So reflect on that and see what tests you can do around that. Thanks, Celine.
Thanks, Dervla. Thank you very much.
Brilliant,
Thanks,
Eric.
Eric.
Thank you for submitting that question. It's really, really good.
You.
I'm afraid, I think we've run out of time now for the rest of the questions, but we will be compiling that question and answer document. I've dropped the evaluation code there into the chat box. If you wouldn't mind just taking that 2 to 3 minute survey just to let us know how we did, how we can improve. And I'd like to hand back to Magella so to close the meeting.
Thanks, Celine. And just very briefly, just to thank you all sincerely for attending. Great numbers on today, and you stuck with it throughout the entire hour. So really thank you very much for that, first and foremost. And to thank Celine for organising the event, for Dr. Dervla Hogan for collaborating with us and working with us from QPS and contributing today, and for Ronan for presenting as well. So thank you all very much, and look forward to seeing you on the next webinar. Thank you.